Well, let's shift to therapy, and I kind of, can expect that there will be a little bit of further debate over here because nothing is clear. If anything, I spoke about BCLC, which is more of a roadmap because BCLC not only classifies patients in different categories in regard to the performance of their liver and the extent of the cancer in the liver, but might recommend some therapy. It's rather a little bit boxed, where in other words, a small disease, good liver might go into surgery. A small disease, bad liver might go into transplant. A little bit more advanced disease in the liver might go into some form of local therapy, and probably some further advanced disease or metastatic disease might go into sorafenib or a clinical trial or what have we. But obviously, there's a lot of gray zone, as you can imagine, like in any other road mapping that we can do for any disease. So let's start dissect a little bit on the surgery front and discuss some of those aspects. So I would say a patient that you might see Amit in the clinic, maybe he's followed or being seen for a hepatitis screen and end up with some lesion in the liver. 1 centimeter, transplant or surgery?
So this is actually a common debate that people have. And I think, if you ask 10 people, you're going to get different answers from
maybe 20,
everyone.
maybe 20 answers.
Yeah, exactly. So I think it's the type of thing where, in my mind, it's a clear distinction. So I think that it really comes down to the degree of liver dysfunction. So for patients who are either non-cirrhotic, which are a minority of patients in the United States, if you're non-cirrhotic, surgical resection should be your primary treatment, and unless not possible for other reasons. If you have well-compensated liver disease, so no ascites, no encephalopathy, and no portal hypertension, and with a unifocal lesion, almost independent of size, it's not the 1 centimeter, it's more so good liver function, unifocal lesion. If you have enough of a liver remnant, surgical resection should be your primary therapy. Only in patients who are not surgical candidates for either degree of liver dysfunction or multifocality should be considered for liver transplant if they're within criteria.
Fair enough.
So I think really the branch point for me is the degree of liver dysfunction.
Fair enough, I can understand. And can you please tell us what are the criteria? Maybe we'll start with the Milan, just because it's probably the most acknowledged ones.
Yeah, so the Milan criteria is you need either a unifocal HCC less than 5 centimeters, or 2 to 3 lesions, with the largest being 3 centimeters, in the absence of vascular invasion or distant metastases.
Fair enough, and that's very important because the criteria were actually built based on a trial by Mazzaferro and colleagues from Milan, and that's why it's called the Milan criteria, which has been reported in the New England Journal of Medicine, really kind of shaped the world or the field of transplant, where pretty much we're transplanting for the liver disease, as we just heard from the expert, from Dr. Singal, and not for the extent of the cancer. And as such, the best outcome, where you have survival that really reach up to the 5 years, is really dependent on having limited disease rather than way too much disease. If you happen to be in some town and there is a transplant meeting, you're gonna hear something called the metro ticket, where pretty much here in New York, if you ride on the subway, you'll pay any price, the same price wherever you go in the 5 boroughs. But if you are in Europe, the further you're away from the center of town, the further you're gonna pay for your metro ticket. Is that right in Italy?
Yes,
absolutely.
absolutely.
And as such, in other words,
you pay for what you get.
Fair enough, exactly, you pay for what you get. And as such, if there is further extent of the disease, the chance of recurrence is much higher. This is the price of the ticket. And as such, there should be some kind of assessment and a very frank discussion regarding if this is really the appropriate choice of therapy or not. Now, let's switch to the other perspective, though, which is, remember that livers are not necessarily always in abundance, and this is the reality of transplant. So we depend on the MELD score. Can you tell us a little bit more?
Yeah, so the MELD score is an objective score based on 3 lab values. So bilirubin, INR, and creatinine. And so based on these 3 lab values, you get a score called the MELD score.
Correct.
And the MELD score is really the priority score for liver transplantation.
Yep.
So the higher your MELD score, the higher you are on the transplant list. Now, traditionally what used to happen with HCC is that you would get an exception score. So you would jump up to a score of 22 and then continue to accrue extra points every 3 months. This scoring system was just changed in the last year, where now patients are listed with their natural MELD, once again based on these 3 lab values. They are on the list for 6 months, and then they jump up to a score of 28. Now, depending on which region of the country you are, a score of 28 or around 30 will get you transplanted. So in Dallas, we're transplanting around a score of around 30. I believe in LA, you're transplanting at much higher MELD scores.
For sure.
Probably around.
And now, with the new MELD system, the liver cancer patient's going to max out at a score of 34, which is the true impact of that in the future, will only be seen.
Yeah, I think in certain areas, such as parts of California and likely even in New York, you're going to see HCC patients that actually can't receive transplants because the average MELD score that people are getting transplanted exceeds that 34 and is closer to 37, 38.
So what does that mean to oncologists? That's a very critical component because, number one, if anything here, we're talking about the rationing of a limited resource, which is the explants or the transplanted liver that we can put in patients that are in need. And as such, if you happen to have a patient that has limited disease, it's very critical and imperative that this patient be referred to a transplant service where they can be evaluated and put on a transplant list as soon as possible because, as we just heard, this is a matter of localization of the resource and same time building the scores as we go, and that's why it's very critical to kind of move in that direction. One thing that Dr. Lencioni, and I know he did not necessarily brought it up from that perspective, if I may correct Riccardo, however, you said that for Charles-Pugh patients, not much of therapy. I know you put it from the perspective of local therapy, but that's fascinating. This is a patient that probably should go to transplant before anybody else if they have limited disease because this is their only chance of probably a cure or potential survival from that illness. So.